talk which was given by Pradeep was very insightful, and probably I would try to stress on some important points so that we know what cases not to be done. But let us try to understand who is a TAVR candidate, and this is a summary slide from ACC AHA guidelines. Uh, Life expectancy, patients less than 65 years of age, surgery 65 to 75 years of age, surgery more than TAVR, surgery equal to TAVR. This is a little bit difference between the ACC AHA and the European guidelines. 75 to 80 years, TAVI more than SAVR, TAVR equal to SAVR, but more than 80 years of age, TAVI is the class 1 indication. Now, how do we apply these guidelines into our clinical practice in India? It's going to be very, very different, individual based. We don't have clear-cut guidelines, but probably we'll try to understand and implement from these two guidelines and maybe come up with something of our own. Surgical risk, STS score more than 8%. We know all these risk scores, so I'm not going to go into details. Then we need to understand the comorbidities, anatomy, and frailty. But the important thing, bicuspid are not included in these studies. That's very important, whereas 30% of TAVR patients in our country are bicuspid aortic stenosis. And if you look at the ACC-AHA guidelines, it is only the transfemoral TAVR, which is class 2A indication, and the non-transfemoral TAVR is class 2B indication. So let's look at some of the examples. 73-year-old male patient, severe aortic stenosis, no risk factors, absolutely healthy, annulus of 743, area-derived diameter of 30.8. Do you want to evaluate this patient? Oh, sorry, the CT scan I have said upfront only. So this is a 73-year-old gentleman, severe aortic stenosis, no risk factors. So in our clinical OPD, we would evaluate this patient for TAVR evaluation. A TAVR evaluation was done, and this was the CT scan findings. CT scan area of 743, area-derived diameter of 30.8, a CT scan annulus, you can see not much of calcium. This is just a sizing chart for everybody to understand that the maximum large possible 29 sapien 3 goes up till recommended guidelines is 683. And this is the CT scan which shows calcification of the raphe. Now, the ascending aorta size is normal, there is no ascending aortic evaluation. So again, comes back to the point, 73-year-old, fit, absolutely fit, healthy gentleman, no other risk factors. TAVR evaluation was done. A CT scan analysis showed calcified aortic stenosis, left and right fusion, and calcified raphe. Now, if you go back to Sushil's talk, he clearly highlighted the mortality was directly related to the calcified raphe and calcification up till 1 year. So do you do a TAVR or not in this patient? You try to do certain more measurements and then think that you might discuss with the patient and the patient family, but as an intervention cardiologist, as an operator, you want to do this case. And then, but the guidelines tells you not to do this case. And they tell you that this patient is probably might do better with surgery. But with discussions back and forth, now we decided TAVR, yes or no. So how many would do TAVR in this patient? So I'm glad. So yes, Sushil has raised hands. Sushil is going to do TAVR. So TAVR, yes or no? So we're going to go ahead and decide. So my talk is not related to the details of doing a TAVR procedure, but this is a balloon aortogram. We decided to do a TAVR patient, and then a balloon sizing 25 mm balloon, no PVL, 29 millimeter Edwards sapien 3 valve, as we highlighted, positioned with the top end of the leaflets, and then the valve was deployed. Looks fantastic, trivial paravalvular leak, everybody is happy. Very good result. Guess the complication in this patient. Anybody wants to take a guess? Just anybody wants to take a guess? What complication might have happened in this patient? Yes, Sushil is right. Patient is in ICU, complaint of nausea, vomiting, persistent headache. Patient was diagnosed to have a posterior circulation stroke. Discharged on day 3. Patient took 2 months to recover. 2 months to fully recover, to walk independently, otherwise he was having all those cerebral stroke. I wish I had not done that TAVR case. I wish I would have sent that patient for surgery, because Sentinel would also not prevented the posterior circulation stroke, and this patient took longer than what the patient would have taken to recover from a surgery. But see, on the other hand, look at this patient. Look at that CT scan. Look at so much of calcium. This patient is still at high risk of stroke, but we would still offer a TAVR in this patient because he's 81-year-old post-CABG. So we need to tailor our patient selection very appropriately. This patient has calcified groin vessels, And now, we went ahead and do this femoral vessel, transfemoral TAVR. While we coming out, when we pull out the sheath, we see a pelvic perforation. Oh my God, we fixed it, but then I wish and I hope I would have chosen a different valve which could have gone easily through a femoral vessels. So again, it is very important when you're selecting the patient, try to tailor the valve or maybe an alternative access. Now we do these different fancy things. We do an IVL, try to optimize the TAVR approach and do these TAVR patients in these cases. Now look at this 78-year-old patient, severe aortic stenosis, tricuspid aortic valve. How many of you would do a TAVR in this patient? Everybody would do. 78-year-old patient, classical tricuspid aortic stenosis, and this is the femoral vessels. Very borderline case, 5 mm, 5.2, 5.3 mm vessels. Now, there's a new valve, there's a new kid on the block, you want to do this valve, and then you went ahead and push your sheath and do the valve. Looks fantastic. No paravalvular leak, no pacemaker, no bleeding. And this is what we notice on the left side. A total closure of the common femoral vessels. We'd fixed it by putting a stent, that's a different scenario, but I wish I had chosen a different TAVR valve. So that's very, very important again. You choose a TAVR platform which can easily go through a femoral vessel. You understand the OD of the femoral sheath and understand the interaction of the femoral sheath with the patient's common femoral vessel. 68-year-old gentleman, father of a physician, that's already a risk factor in India. Presented with dyspnea on exertion, standard history, standard symptoms, TAVR or no TAVR. 68-year-old patient, yes, we would offer a TAVR evaluation for sure. This is the CT scan, no calcium in the annulus, a bicuspid anatomy, 26 millimeter sapien 3. So 26, when patient gets a 26 balloon expandable valve, the annulus is a good size annulus, and if you have to think of a lifetime management, let's say this is a 68-year-old gentleman, and we can go ahead and treat this patient fast. So after the CT scan, patient's son, who's a physician, comes up and says that he has an appointment with another cardiac surgeon in Delhi and wants to have a second opinion. This is a red flag, don't do this case. But anyways, this patient comes back. And then we implanted 26 valve, which is just 2% oversize, and this standard steps, a 26 valve is deployed. Everybody is happy, but immediately patient had a collapse, pulse electrical activity was done. We show a massive pericardial effusion, pericardial tamponade. We were lucky by the time the surgeon was getting ready, we put some coils in that patient and the pericardial annulus rupture was sealed. And we also reported this case of a transcatheter percutaneous coil management in this patient. So this is my last summary slide. So these were a few cases which highlighted, didn't wanted to do them, but you ended up doing them. So how do we evaluate? What is the take-home message? Now let's say you have a TAVR eligible aortic stenosis in your OPD. You do a risk assessment. You do a surgical risk assessment. Now the surgical risk is low. High surgical risk, don't have to focus on it. But the TAVR eligible patient with low surgical risk, you assess the TAVR risk. We don't have special guidelines, but what is the TAVR risk? TAVR risk depends on the anatomy, TF access, and the operator volume. If your TAVR risk is low, go ahead and do a TAVR patient. But if you feel the TAVR risk is high, do a surgical aortic valve replacement. Thank you very much for the kind attention.